Okay, so now we're switching gears going into antidiuretic hormone imbalances, more on your endocrine system. We're going to talk about diabetes insipidus and syndrome of inappropriate diuretic hormone. Both of these are going to be found in your ATI and your Lewis book. Okay, so as I mentioned, we are now switching gears and we're going to talk a little bit about DI and SIADH. As mentioned before, these two are going to be different from the diseases we just talked about. This one is more specific to your pituitary gland. And if you remember back from when you first took pathophysiology, we know that the pituitary gland is also known as a master gland. And this is because it secretes very important hormones and it helps regulate our endocrine functions. And it has two parts. Remember, there's an anterior and a posterior pituitary. And the diseases we're going to talk about, the prime focus is going to be on the posterior pituitary. The posterior gland is primarily made of nervous tissue and its function is to store and release ADH, which is our antidiuretic hormone. The purpose of ADH is also known as vasopressin, and as you rotate through the critical care units, you'll see that we actually give vasopressin as one of the most more potent vasoconstrictors. It's one of our last resorts when we need a patient is in severely they have severe septicemia and they need a lot of assistance with their blood pressure. We will use vasopressin at very low doses. It is to control serum osmolality and water balance. It does this by decreasing urine production and also by reabsorbing water back into our circulatory system. Our TSH hormone is produced by the pituitary gland and it stimulates the thyroid gland in response to different levels of our T3 and our T4. And this is to either increase or decrease the levels in our blood. So there's two primary pituitary disorders, and those are going to be our diabetes insipidus and our SIADH. So if we look at some of the information on the slide, we know that ADH, as mentioned, is secreted by the posterior pituitary gland, or aka the master gland. Hormones are released as a message in response to either hold on to fluid or release fluid. The target organ is our renal tubules, and it increases the reabsorption of water back into our circulatory, or on the other hand, it decreases urine output to hold on to fluid. Some of the target tissue can be our arteries, which I mentioned before when we talk about vasopressin, it causes vasoconstriction. And the antagonist is aldosterone. Okay, so let's talk a little bit about what diabetes insipidus is. This is also known as central diabetes insipidus, and this is caused because of our hormone, our antidiuretic hormone insufficiency. So what happens is with this insufficiency, it leads to excess fluid excretion. Usually a result because there could be damage to our hypothalamus or our pituitary gland. Remember, our pituitary gland is the one responsible for ADH. Things that can cause this can be either head injury, neurosurgery, pituitary tumors, brain infections, because all of this can cause swelling in our brain, which can cause. I remember early in week 1, I talked about our brain only has room for 3 things in our head, and that is CSF, that is blood, and that is tissue. And when there's either one or more of one or the other one has to give. So what happens with this is when we have brain infections or any kind of neurosurgery, now we have a little bit of edema. So that's going to cause a little bit of compression in our hypothalamus, which can cause a little bit of interference with our ADH production. So usually our hypothalamus is the one to detect dehydration, and it signals the pituitary gland to hold on to water or reabsorb water. But because there's insufficiency of this hormone, large amounts of urine are excreted because the stop sign is not available. So it just keeps going and going and going. So we have cell membrane permeability to water, and it's decreased, and the result of that is that excretion of large amounts of hypotonic fluid, up to 12 liters per day. None of us can afford to release 12 liters per day. This is a massive amount of large fluids. We have neurogenic diabetes insipidus, which is a lot more rare than central diabetes insipidus, but it is caused by the kidneys failing to respond to ADH. So with this one, it can be caused by kidney disease, hypercalcemia, even some effects of certain medications can cause this. Diabetes insipidus is often acute episode, but may become chronic, requiring lifetime treatment. Okay, so going back to DI, we know that this patient has decreased ADH. Some of the resulting effects due to this decreased ADH is that they're going to have decreased water reabsorption. So they are very dehydrated because since they're not absorbing any water, they're going to have a very high urinary output. May even go up to 20 liters per day, anywhere from 12 to 20. So as I mentioned, it's just very large amounts of volume that are being lost. And they'll have decreased urine osmolality because remember, they're releasing so much urine that they have less particles in the urine because the volume is so high. If you could think about the analogy that I used with some salt in a cup of water, and when you dilute it, think about that as osmolality because there's particles. But because there's so much volume coming out of the urine, there's going to be less particles in the urine itself. That's why we say decreased urine osmolality. At the same note, they're also going to have decreased urine specific gravity. There's going to be a lot more water out than solutes, which goes back to the same concept of urine osmolality. They're going to have very low intravascular volume because they're very dehydrated. There is not enough volume in the circulatory system. Because of that, they're going to be hypotensive. They're going to have decreased blood pressure, increased serum osmolality with severe dehydration. They're going to have increased serum osmolality because there's going to be less volume of blood in the circulatory system, so there's going to be more particles in the blood. They're going to have decreased cerebral tissue perfusion. They're going to have hypernatremia, and unfortunately the outcome is hypovolemia that can lead to shock. Some of the things that you can remember that are very specific to DI is polyuria, polydipsia. They're going to be very thirsty. They're going to have nocturia. They're going to have decreased weight because they've lost so much fluid. Remember, fluid and daily weights is a good indicator on how much you've lost. That's why it's important to do daily weights on our renal patients because we need to know how much volume they're retaining. Same thing, although different diseases, but we need to make sure that we're doing daily weights to assess our fluid losses. They're going to have increased heart rate because our heart has to work harder because there's less circulatory volume. They're going to have decreased blood pressure because there's less volume, so the body is going to be hypotensive. They're going to have muscle weakness, syncope, and constipation. Okay, some more manifestations. I talked about some of these in the previous slide. So I mentioned that they're going to have a lot of polyuria. When you see the urine coming out of these patients, it is almost like water. That could be a sign. If you notice yourself constantly emptying out the Foley catheter, you need to start thinking DI, especially if it's a neuro patient. They're going to have excessive amounts of urine output. Nocturia, they're going to have urgency, and they're going to have frequency. Keep in mind that we talked about that this patient is going to be thirsty, and they're going to tell you they're thirsty. However, if you have a patient in a critical care setting that may have had some neurosurgery or has some kind of head trauma, they're not going to be able to tell you that. So you would have to be the one to notice that these manifestations are going on with your patient, how they're going to be presenting to you. So if you ever take care of a neuro patient and you start seeing excessive amounts of urine, you need to think quick and think about diabetes insipidus and notify your doctor, because you need to start drawing some labs and make your comparison to see if this patient truly is in DI. Polydipsia, it would be a compensatory response to the fluid loss, because um, like we said, they're going to be thirsty, so they're going to get that polydipsia. They're going to have that excessive thirst. Then they're going to have poor skin turgor, because they're going to be very dehydrated. Hypotension, tachycardia, weakness, fatigue. They're going to be irritable. They're going to be confused. If this diabetes insipidus is not managed, they can go into lethargy and eventually into coma. So it's very critical that we find out what's going on with our patients early. Early intervention is always a million times better than late interventions, because when it's late, then we're dealing with a different situation. Now we could be dealing with someone with a coma now, when we could have caught it early. So always keep those kind of things in mind. This is a mnemonic that I would like you to remember. When you're thinking about DI, think about the 6 Ds, because these 6 Ds represent your patient. They're going to have a decrease in weight because, as mentioned before, they're losing a lot of volume. Dry mucous membranes, because they're going to be incredibly dehydrated. They're going to have an increase in their thirst mechanism. They're going to have decreased blood pressure for the low circulating volume in our blood due to all the volume that we've lost. Decreased skin turgor due to the dehydration. Decreased fluid in our circulatory system, which causes the decrease in BP. But at the same note, because there's less to pump out, the heart has to work harder, so you're going to have an increase in pulse. Then, of course, we're going to have that decreased specific gravity. Now, turn that around and think about your labs. Now, with your labs, they're all going to be increased. You're going to have an increase in BUN, serum osmolality, your sodium, and your hematocrit. Uh, this diagram here is just showing you your diabetes insipidus in a picture to try to help you remember. And I'm going to talk about some of the treatment interventions in the next few slides of what we do. So very important, monitor fluids, replace fluids, check your neural status, check your vital signs, check those simple things that you've learned in fundamentals when you want to check for a patient with dehydration. Okay, now some of the treatment interventions that we're going to do is we're going to do some serious fluid resuscitation. These patients have lost so much volume that they need to have fluid replaced. And a good way to try to remember some of the interventions that we're going to do is if you think of the term fluids. The F will stand for fluid replacement, which is what is required for these patients. L would be for level of consciousness, because remember, we need to always monitor safety for these patients. So if there is a change, or you notice that the neural status is starting to go down on your patient, you need to make sure that you report this to the patient's MD. UN fluids for urine. Remember, they're going to have large amounts of urine. Some books will say anywhere 4 to 20, some will say 12 to 20. You're safe to say they can lose up to 20 liters per day. Then you have the I in fluids for monitoring your urine and output. You want to compare and contrast trends. Remember, the body doesn't like rapid changes, so you want to make sure that they're not huge differences in trends. You want the D in fluids is going to be so you can document daily weights, monitor any trends and vital signs again. The S in fluids is for safety. These patients are at risk for mental status changes. So anytime someone can go into a mental status change, it can put them at risk for seizure. So you want to make sure that you have suction available. And then another S for safety would be for medication administration of vasopressin. Got to make sure that replace output with intake, and don't forget about the electrolytes. And you may have a protocol you're following, or it's going to be per MD order. Now, often this is caused by head injury, so monitoring neural status is very important. There's this example here, and we have a patient with a blood pressure of 80/20, heart rate of 160, elevated temp. The skin is dry with oral mucous membranes, and a catheter is inserted. You get 800 cc's of urine out. So because it's almost a liter, you're going to need 1 liter bolus for these symptoms until urine specific gravity is now greater than 1.005. So you need to replace 800 mLs per hour per output, total of 800 mLs per infusion. Don't worry too much about that. This is a complicated concept. Just keep in mind, as a novice nurse and you're taking care of these patients, fluid resuscitation is important. Trying to find out what these patients look like is important. Learning some of the assessment findings, which we've talked a lot about, is important. So don't worry too much about this. Just know that fluids are going to be replaced. because we want to prevent hypovolemic shock. Now, as far as treatment interventions, the very first thing we want to figure out is determine the cause. Finding out the cause is going to help us with once we deal with the acute symptoms, then we're going to figure out a way on how to prevent this on our patients. So determining the cause would be an important thing to do, but not initially, because remember, safety first. We want to prevent this patient into going into shock, hypovolemic shock. So one of the treatment interventions we do is we use a medication called desmopressin, may also be called DDAVP. And what this medication is, it's just a synthetic replacement of vasopressin. And once we give the vasopressin, that's going to reduce urine production. It can be taken nasally, like a nasal spray. It can be given IV. It can be given oral, or even a sublingual tablet. So there's different ways of administering this medication. It tends to be usually the drug of choice for most physicians. We're going to monitor our patient very carefully. We're going to make sure, I've talked a lot about this, vital signs, urine output, specific gravity. We're going to make sure that we're looking at the respiratory system, because we want to look for hypervolemia that can lead to pulmonary edema, because we're going to be replacing so much fluids that at the same note we want to make sure we're listening to those breath sounds. If you remember from the respiratory lecture, we talked about how sometimes people will have crackles, and if someone has crackles, that's usually an indication of fluid volume overload. Look at that JVD. Remember, these patients are initially going to present very dry, but because we're doing massive amounts of fluid replacement, we also got to watch out for hypervolemia. Labs, I talked about the sodium, I talked about electrolytes, serum osmolality. We do check blood glucose levels because we want to prevent hyperglycemia, and we always want to go back and evaluate the effectiveness of the treatments that were done. Some quick things to remember is just a quick overview now on some of these concepts of diabetes insipidus. The patient is going to have an increased sodium level. That is because they have hemo concentrations. They're going to have increased dryness of mucous membranes because they're incredibly dehydrated. They're going to have increased urine output because they don't have the ADH, and they're going to go ahead and just release so much amounts of urine output. They're going to have increased deep muscle tendon reflexes. They're going to have increased flushed red skin, increased restlessness, confusion. They're going to have hypernatremia. They will have an increase in temperature, and if you look at the little scenario I gave you, that what patient had an increase in temperature, they had a decrease in blood pressure. But right now I'm only talking about all the increases. So they're going to have an increase of thirst mechanism, maybe decrease in the elderly. I did talk about the elderly and how they have a depressed response to thirst. Increased risk for seizures. Anytime we're dealing with the brain and we're dealing with sodium, they can have an increased risk for seizures. They're going to have increased heart rate. Now the only thing, now decreased things, they're going to have decreased blood pressure, decreased CVP. And if we remember back our lecture on week 1 when I talked about hemodynamics and I talked about CVPs, I said anytime you have an elevated CVP, that means there's too much volume. But on our patient that has diabetes insipidus, they're going to have a decreased CVP because they are dry and they're dehydrated, so they need volume. A good thing to remember is that the serum sodium is high because the patient is dry. So just think about what a dehydrated patient looks like. And usually with hypernatremia, that's because of the excessive fluid loss from the lack of ADH, and that's typical in our DI patients. Many times sodium does need to be restricted when the sodium is high. So they'll have diets with very low sodiums. Another thing to remember, or just ways to help you remember DI, is think about dried. Remember, this patient's going to be dry. So think about dried, DRIED. They're going to have dry mucous membranes. They're going to have urine output for this patient is going to be high. They're going to have deep muscle reflexes. They're going to have red flush skin. Now this is a R in dried. Review the labs, sodium. They're going to have increased temperatures. That's the I in dried. I in O's. No increase in urine concentration. No increase in thirst. No seizures. Now this is your expected outcomes. So your expected outcomes are going to be dried. Okay, so our expected outcome, I'm going to start again just because I don't want to confuse you. Dry mucous membranes, urine output. Our outcome is we want within normal limits for our patient. Deep muscle reflexes within normal limits for our client. Now as far as the red and dried, red flush skin won't be present. Restlessness or progresses to confusion, alert and oriented. We want to keep our patients alert and oriented. Another R for dried is review the labs. Look at those serum sodiums. We want the serum sodium to go within normal limits. I in dried is increased temperature. Make sure that we're watching those eyes and noses. E is elevated heart rate. And we would want our patient to have a normal heart rate, so within normal limits for our patient. Then the D in dried, decreased weight. We want our patient's weight to be within normal limits. And we want normal CVP because they're going to have decreased CVP. And just think about, and remember, I don't want you to focus too much on numbers. Just know when it's low, what it means, and low when it's high, know what that means. Okay, so now we're going to go ahead and start talking about SIADH, which is a syndrome of inappropriate antidiuretic hormone secretion. When we talk about syndrome of inappropriate diuretic hormone, one of the things you want to know that usually is a good way to remember, which is the way I used to remember it, is syndrome of increased antidiuretic hormone, because really what it is just an excessive antidiuretic hormone release. So we have now, it's going to be the complete opposite of diabetes insipidus. Now we have too much of it, so the body now cannot excrete water, or with the patient's actually going to go into hyponatremia. If you recall, with DI, they were in hypernatremia. So what happens is that the continued release of ADH now is causing water to stay within your circulatory system. So now we have a lot of water retention from the renal tubulars. Now we have an extra fluid volume increase. So now we have a fluid volume overload. Some of the etiology, well, I talked about that, just syndrome of increased antidiuretic hormone. Some of the causes can be brain, pituitary tumor, any kind of cancers, head injury, infection, drugs. Usually some of the common ones are anti-seizure, antidepressants are some of the most common ones. So what you're going to see is that there's going to be increase of water reabsorption in the blood. Some of the system assessments that you'll see is they're going to have an increase in blood pressure. They're going to have an increase of respirations, dyspnea. They're going to have orthopnea. They're going to have crackles in the lungs, because now let's start thinking about fluid volume overload. They're going to have increased JVD. They're going to have increased pulse, maybe normal, but this patient's going to have a bounding pulse because there's too much volume, and they're going to be confused as well. And they can have an increase of weight greater than 2 pounds in 24 hours. Uh, these patients, normally when you think about fluid volume overload, immediately you're going to think edema. These patients actually do not have edema because it's water retained, not sodium, with SIADH. And a lot of your patients that have the edema is because they have sodium retention. So I talked about weight gain, pulmonary edema, and cerebral edema. Uh, the decreased serum sodium because it's going to be diluted, and that decreased serum sodium does cause cerebral edema, seizures, and coma. Same like our other patient with DI. That's a little bit of the similarities. So some of the manifestations that this patient is going to have is that they're going to have decreased serum sodium, usually less than 135. They're going to have decreased impaired cerebral function, decreased LOC, which is risk for seizures. They're going to have decreased deep muscle uh, tendon reflexes. They're going to have decreased urine output. They're going to have decreased muscle strength, so these patients are going to be weak. They're going to have concentrated urine. They're going to be thirsty despite that. They have a lot of excess fluid volume. They're going to have a weight gain. Uh, Bounding pulse, I talked about that. May present with abdominal pain and cramping. And I talked about the rest with the headache, confusion, lethargy. So with the slide actually ended up cutting off on me. But going back to some of the treatment interventions, we're going to give this medication called declamycin. And declamycin is actually an antibacterial agent, but it does have an effect where it's going to block the effects of ADH on the renal tubules. So with that, it's going to help the patient to release some of this excess fluid. Another thing we want to do is we want to monitor serum sodium. Sodium, as we mentioned before, it becomes one of those critical electrolytes for these patients, because if the sodium gets too low, we are going to have these patients be at risk for seizures. If it's lower than 120, we do want to slowly give a hypertonic saline IV solution, usually like a 3%. Now, one of the things that we have to be very careful with is that we don't want to raise the sodium too fast because of the changes it can do in the pons in the brain. So when we do raise it, we raise it very slowly, and we are monitoring these patients very closely to the point where we can be drawing some uh, sodium levels sometimes every 2 hours because of the change that it can do to the brain. So we have to do this as a protective mechanism for the brain, monitoring them so often. If it's higher than 125, then the treatment interventions at that point is going to be diuresis of fluids. We can give Lasix to get rid of this excess fluid. We're going to monitor and correct all of these electrolytes, especially if a diuretic is used, because if you use Lasix as your one of the diuretics, then there's another electrolyte you need to monitor, right? Remember, we lose potassium when we give Lasix, so we're going to be monitoring that as well. Now, another first to do priority intervention, if you break down sodium, let's now break this one down. It's another mnemonic for you to remember. S will be for seizure precautions, because the sodium is going to be so low that it becomes dangerously low, so patient's going to be in seizure precautions. O is for who this occurred in. It can occur in patients with Addison's disease, someone with diabetic acidosis, patients who are NPO, um, SIADH, perspiring, vomiting, diarrhea, burns, or administration of D5W. Then we have the D for daily weights. We're going to give them foods high in sodium and anything that's prescribed by the physician. The I, if retaining fluids and we want to restrict fluids. You understand the cause. We give IV fluids as directed. But remember, normally we will restrict this. And for monitor vital signs. I's and O's, weight's the best indicator of fluid status. Skin turgor, neuro assessments, and we're going to monitor this patient for fall precautions. Any kind of changes, neural changes, we're going to make sure we position slowly. This slide here is a good one to remember to kind of like do a compare and contrast with both of the diseases, one with DI and one with SIADH. I did want to talk a little bit about the previous slide, so if you can actually go back to your notes, because what ended up happening is I got cut off and then it cut me off completely. So I want to talk about some of the things that you might have missed because it didn't record. So I wanted to talk about some of the differences. I'm sorry, not some of the differences, some of the treatment interventions. I think by the time you might have listened to that slide, which is the previous one, syndrome of inappropriate diuretic hormone, it cut off the beginning portion of what I wanted to talk to you about. So the treatment that we're going to do for these patients is that we're going to go ahead and restrict their IV fluids. If you look at the word restrict in your previous slide, R is to reduce the IV fluid. E, we're going to evaluate breath sounds. These patients are at high risk for fluid volume overload. We want to monitor for any kind of pink tinge frothy sputum, which can be an indication of pulmonary edema. S is for keeping this patient sitting upright in a semi to high Fowler's position. Remember, they're high risk for seizures, so we want to make sure that they have a protected airway. We don't want this patient to aspirate, because if you remember back to our respiratory lecture, one of the reasons why people get ARDS was from aspiration pneumonia. We're going to go ahead and treat them. The T for treat with oxygen and diuretics is ordered. One of the common diuretics we use is Lasix. Then the R for restrict is reduce fluid sodium intake as prescribed. We want to give them sodium, but you're going to reduce fluid. Sodium that we give can sometimes even come in tabs. What these tabs are is a compressed salt that is made in a pill form, and many times the physicians will have a nephrologist be a consultant or get a consult from them to help manage these patients, and they'll be the ones that keep a very good eye on the fluid and electrolytes, which is why we end up consulting with them. The I in restrict is for daily I's and O's, daily weights. I'm sorry, not daily I's and O's. Strict I&O daily weights. We're going to do compare and contrast. We're going to look for different trends to see if this is we're having huge changes in our trends. C is for circulation. We want to look at the patient's color and their LOC. T is for turn and position every 2 hours. These patients' skin is at high risk for breakdown because it tends to be moist. So we want to make sure that we keep their skin nice and dry. One of the things to remember is that they're going to be in fluid volume excess. They're in fluid volume excess because they have an increased level of ADH. That increased level of ADH now, remember SIADH, syndrome of increased antidiuretic hormone, they're going to have increased fluid volume and a decreased sodium because it's diluted. This is for the fluid volume excess. Another thing that I did want to talk about is that we will restrict these patients sometimes only like 500 cc's in a 24-hour period. They cannot have any water, so it's important to educate family that they're not going to be able to have any water, because the very first thing someone wants when they can't have water, they're going to want water. So you want to educate family the importance of making sure that they do not have any excess water or any additional water, because we are restricting that because of their sodium levels. One intervention that you can do is when someone's incredibly thirsty and they cannot have water, is you can give them a peppermint to suck on, hard candy. Some of this will prevent them from thinking about water because their mouth will be nice and moist, so they're not going to really even think about it once you give them that. Another thing that we can do with these patients is I don't know if we were able to talk about the medication that we use. don't know if that was one of the ones that got cut off, but we do use declamycin with these patients, and what it does is that it blocks the effects of the on the renal tubules. So if you give this medication, well, one of the things you're gonna be looking out for is for a decrease in urine output. I'm sorry, not a decrease, an increase. So what you want with the declamycin is you want to start seeing this patient urinate, because remember, these patients are not urinating. They have a very low decreased urine output. They're going to be the complete opposite of DI. Remember, DI, they're peeing, peeing, peeing. Now with SIADH, they're not peeing. So when you give the medication declamycin, you want to check for urine output increase. Some of the electrolytes that some of the changes you're going to be looking for, some of the assessments, is that they're going to have a decrease in serum sodium less than 135. They're going to have a decreased impaired cerebral function. They're going to have decreased muscle strength, decreased deep tendon reflex, decreased urine output. The increases are going to be an increase in blood pressure, increase in weight, and a good way of remembering this is because of the increased ADH, they're going to have fluid retention. That excess fluid retention decreases your serum sodium because it becomes dilute. Low serum sodium equals a wet patient. And you think you did get the mnemonic for sodium. And this, now going back to this slide here, this one's just giving you a comparison of what's going on with your patients and the differences with each. This is another one that you'd like to look at, which is going to be the differences. You're going to see a good comparison, and if you look at them, you notice that they're complete opposites of each other. So that's a good way of remembering your patients. Remember, with your electrolytes, your SIADH patient is going to have low serum sodium. DI has high serum sodium. If you want to memorize one, but you got to memorize it really well and understand it, then you know that the other one is going to be complete opposite. Now, as far as delegation, when you delegate anything to a new grad, a good way of remembering delegation questions is that you would delegate to them the level of care that you would delegate to a LVN. Yes, I know that they can assess, but you always want to give them the most stable patient. Patients with SIADH, you want to make sure that you're monitoring specific gravities, because if you look back a few slides, I talked about that, and that's one of the monitoring things that we do based on some of the medications that we give. And this pretty much concludes this PowerPoint presentation.